We had no disclosures. So we know that urgency is the cardinal symptom of overactive bladder, and women with urgency typically use the words fear of leakage, and this is also the ICS definition of urinary urgency. The very fact that the word fear appears in the description of urgency suggests that it likely involves several areas of the brain that form a network. Functional MRI studies, of which there are plenty, do bear this out, and several cortical and subcortical regions have been identified as being activated in women with overactive bladder. What we know less about is how are these regions connected to each other. And understanding these connections could provide insights into mechanisms underlying overactive bladder. In traditional connectivity analysis, such as seed-based techniques or ICA, we measure temporal connections between the different regions of the brain, or the time course between which region is activated first and which region is activated next. And by and large, these connectivity studies have told us that subcortical regions during bladder filling are suppressed by higher centers. What we don't know is how does urgency affect the entire brain network? And secondly, can connectivity be measured quantitatively? So in recent years, graph theoretical analysis has been used for understanding networks. And according to this graph network theory, the brain network is optimally organized for efficient segregation and integration of information. So in graph theory, to study the brain, to study the networks, we have to know what nodes are, which are these red dots, and these are the anatomically defined regions of the brain. Edges, or which are the blue lines between the dots, is the functional connection, which is essentially the bold signal between two nodes. According to graph theory, there are three kinds of networks: the regular network, the small world network, and a random network. In a regular network, as you can see, each anatomically defined region is connected to its neighboring nodes. In a random network, there is no pattern to the connections, and these kind of networks are not terribly efficient. Regular networks have low cost of operation, but again are not efficient. A small world network represents an optimal balance between the energy that it takes to run the network and the efficiency of the network. The objective of our study was to determine if the concept of small world networks could be applied to micturition. Our primary hypothesis was that change in patient-reported urgency correlates with change in small world network metrics, and our secondary hypothesis was that there are significant differences in small world metrics in women with OAB and controls. We studied 13 women with OAB and 12 controls. These are a few of our exclusion criteria. At baseline, all women completed the ICIQ FLUTS questionnaire. The first scan was performed immediately after voiding, when the urgency score, as measured by a visual analog scale, was less than 3. The second, or the high urgency scan, was performed after the patient had drank about 250 ml of water, and she reported an urgency of at least 7. Images, the fMRI bold images, were obtained on a 3T Simon scanner. Data processing for graph theory analysis was done using some in-house toolboxes and also the Gretna toolbox. Using the software, nodes were identified, which is basically automated anatomic labeling of the brain regions. Edges represented the functional connectivity signal in the resting state between these nodes, and from this information, the small world metrics were calculated. So these are the small world network metrics that we calculated. The first is the path length, which represents the distance between two nodes. Then is the clustering coefficient, which is basically how closely are nodes clustered with each other. Sigma is the extent of small worldness, to what extent does a given network meet the criteria of a small world network. And the way that is done is, first, the path length has to be expressed in relationship of a real network. In this case is the maturation network in relationship to a random network. A lambda is calculated. Similarly, when the ratio is of a maturation network to a random network is calculated, that's gamma. In order to be called a small world network, typical small world networks have gammas and lambdas that are around 1, but the sigma, which is the ratio of gamma over delta, should be greater than 1. We also calculated the global efficiency of information transfer in this network. This is our clinical data. The age and the BMI were comparable between groups. The urgency border score predictably was higher for overactive bladder patients, and the bladder volume measured by ultrasound during the high urgency scan was lower for women with overactive bladder than controls. So here are the small world metric data during the first low urgency scan. And here the blue represents overactive bladder patients, red is the data for the controls. On the x-axis here, we see the different metrics that were measured, and we can see that the path length and the gamma were in the neighborhood of 1. But importantly, the sigma was greater than 1, which suggests that the maturation network for both cases and controls in the low urgency state met criteria for a small world network. When we looked at the path length, the lambda, that was significantly lower in OAB than controls, and the global efficiency was significantly higher in women with OAB than controls in the low urgency state. When we looked at the metrics in the high urgency state, the sigma did meet the criteria for small world network being greater than 1. However, there were no significant difference in small world metrics between OAB and controls. Next, we looked at the relationship between the change in urgency and the change in different small world metrics. And here we see that in women with OAB, change in urgency were correlated with change in path length. However, in controls, no such relationship was seen. Similarly, change in urgency correlated with change in clustering coefficient in women with OAB, but not in controls. And finally, change in urgency correlated with change in the small worldness index in OAB, but not in controls. Therefore, we concluded that the maturation network is in fact organized as a small world network in OAB and controls, and that this network organization is preserved in both the low and the high urgency states. The OAB brain also seems to adjust its topology in the empty bladder state to compensate for the high urgency during bladder filling, and we base this conclusion on the fact that we observed a shorter path length and higher efficiency of transfer in information transfer in women with OAB as compared to controls in the low urgency state. Finally, we observed that changes in urgency were associated with change in small world metrics in OAB, but not in controls. And we are at the moment looking upon this as a possible adaptation response of the brain in the low urgency state in women with overactive bladder. So our ultimate conclusion then is that the small world network is a useful framework for quantitatively measuring connectivity between brain regions in urgency states. The good news is that the small world metrics correlate with a patient-reported measure, urinary urgency, and therefore this information could be applied clinically. Now, as we know, we had observed a short path length and higher global efficiency in the low urgency state. And of course, this is based on a really small sample size and would need to be confirmed in larger studies. But if this observation is in fact true, these findings seem to suggest that there are differences in the brain networks of women with ovarian controls at baseline. And this then provides us, at least provided me, with an important insight into mechanisms of overactive bladder that leads me to think that treatment should be directed not just to reducing urgency during bladder filling, but also we should think about treatments that are directed to the empty bladder or the baseline state. Thank you.
Questions, please. Yeah.
Very interesting. I have a question on the underlying theory of what you're doing. If I understand your cartoons in the beginning correctly, a small network is characterized by many very short and a few quite long connections.
Correct.
If that is the case, path length, which is one of your key parameters you're measuring, based on theory, should exhibit a bimodal distribution and not a unimodal distribution. However, if I understood your calculations correctly, you treated it as a unimodal variable by calculating mean length, which for a bimodal distribution on theoretical grounds is inapplicable. Just to illustrate that, a change in mean length in the bimodal could be just more short ones or fewer long ones, but it could also be that the length of the short ones changes or the length of the long ones changes. As long as you look at this as a unimodal distribution and not as a bimodal distribution, you have no way of telling. So how do you, am I misunderstanding all of this? Or how do you account for that?
So first of all, I'm not aware that there's a bimodal distribution. But
it must be based on your model.
No, absolutely not. I don't think so. This is just a diagrammatic representation of what's going on. And we have to also understand that we are talking about millions of connections here.
Absolutely.
And because there is such a large number, and now I'm really stepping beyond what I do, because I'm working with a neuroscientist, and this is really a question for neuroscience, not for a clinician such as myself. But my understanding is because we are talking about so many different connections, we could sort of, in a way, treat that, apply normal statistics to that.
Okay. I just would like, I have not seen the raw data. I'm just looking at this from the view based on your cartoon, where it looks like you have a few centers with as many short connections plus a small number of long connections. And that would imply a bimodal or more than bimodal distribution to actively check whether this is true, because that would, if present, would challenge your overall calculations.
So there are lots of long connections and lots of short connections. The only difference between these two, between the random and the small world network, is that the random network, you cannot detect patterns or these modules. So in the small world network, these kind of modules start appearing. And the network analysis in neuroscience has really not the beginning, it's almost the end. It has really started from social network theory and economics, et cetera, So the techniques that are used for analyzing these networks are pretty well validated.
So I just want to make the suggestion, formally check for unimodality, because that's an implicit assumption of all your calculations. And if this assumption is violated, you may be misled. So formally check for that.
Francisco Cruz from Portugal. Congratulations, it's a nice paper.
Thank you.
Most of the patients with OEB have adaptive behaviors between the diagnosis and the treatment. Can this small world network be the consequence of those adaptive behaviors, and they might go away once the treatment becomes effective?
So could you repeat that? I didn't get it.
So patients with OEB have adaptive behaviors. They increase frequency to avoid urgency. They tend to identify places where they can void.
Right.
They might change the way they dress, things like that. Can these adaptive behaviors be the consequence of this, or be related with this small world network, and this small world network disappear once those adaptive behaviors are gone?
Yes, that's exactly right. Like you are miles ahead of everyone else. So basically what has happened in social network theory is that they have done analysis of brain networks, not just to see differences in the brains of people, but then to correlate that with how people actually behave and be able to see that the brain networks of people who are behaving in certain ways is actually similar to each other. And ultimately, doing this kind of network analysis in overactive bladder would help us understand why certain behaviors happen, what is the mechanisms. These changes in brain networks are not necessarily always harmful. So a lot of this study has been done in sleep deprivation studies. And in these studies, you have certain harmful effects on cognition, such as worse attention, but you can also have better effects, beneficial effects, such as improved learning. So and then you can use the improved cognitive effect to leverage, to counter the harmful effects. So the next step in something like this would be to study the effect on cognition and then ultimately on behavior. And then that would also give us a better idea of when and where and how to intervene.
Yeah, I think we have to move on to the final question. No, you have your chance. Yeah.
I would just say from a clinical perspective, we know lots of patients are wired differently. How plastic is this? And is it cause or effect? Is this become this way because of an overactive bladder? Or are they basically this way, which is promote them to have overactive bladder?
Yes. So that's the million-dollar question, isn't it? Is it the chicken or the egg? And I suspect it's both. Certainly, we have to look at it from this kind of network analysis, which has been done for social anxiety disorders and sleep deprivation disorders. You can see baseline changes in subjects. Well, the question is, did a phenotype induce this kind of observed genotype that we are seeing, or was the observed change there to begin with? I don't know that we'll ever get the answer to that, and I don't know how hard we need to look for that answer, just knowing the fact that we had differences at baseline and then trying to figure out how to change that baseline.
Thank you.
Yeah, Carl-Erik has insisted on a final question.
Small question, and that concerns semantics. I mean, we all agree that OAB syndrome females have urgency. Normal females don't have urgency. They have an urge. And you measure, according to your scale here, a high urgency state both in normal women and in... Is that the same thing then you're measuring?
Yes. So yes, you're right. That is semantics, and that is correct. And that is why we had a scale, the visual analog scale, and both in OAB and controls, we went by the scales, whatever term we want to use, whether we just want to call it a strong urge to urinate for women with controls, for the control women versus urgency in the cases, we can do that. I think we loosely used the word urgency, but it was objectively measured using a visual analog scale.
Yeah.
Thank
Okay,
you.
thank you very much.